Good evening, and thank you for joining us for this virtual community lecture based on digestive health and irritable bowel syndrome. I'm Nicole Brown, MSN RN certified nurse in the operating room, also the assistant nurse manager of perioperative services at Little Company of Mary Torrance. We are joined by expert gastroenterologist, Dr. Alexander Nguyen. And before we get started, I want to let everyone know that this is an hour-long presentation, and we will have plenty of time for questions at the end of the presentation. Please use the question and answer, the Q&A box, to type any questions you have throughout the event, and we will do our best to get to each question at the end of the presentation. We will not be opening it up for attendees to speak on this webinar. Before I introduce our speaker for the evening, I'm thrilled to share a little bit about our digestive health services that we offer at Providence Company of Mary. We have an array of gastroenterology services and we're also open Monday through Friday. We have excellence. We have staff that hold standards of excellence, and we have cutting edge technology and equipment. Now, it is my pleasure to introduce Dr. Alexander Nguyen. Dr. Alexander Nguyen is a board-certified gastroenterologist with specialized training in advanced endoscopic techniques and medical treatment of complex biliary and pancreatic disorders. He is a practicing physician with the South Bay Gastroenterology Medical Group, where he seeks to provide the best care to patients in the South Bay. As a gastroenterologist, Dr. Nguyen manages and treats general gastroenterology disorders, including irritable bowel syndrome. He also has additional specialized training in advanced endoscopic procedures, such as endoscopic retrograde pancreatography, also known as ERCP. We'll try to say that 3 times at once. So, endoscopic ultrasound, or also called EUS, endoluminal stenting and control of bleeding or fistulas, and endoscopic mucosal resection techniques, or EMR. These procedures are used in the diagnosis and treatment of biliary and pancreatic disorders and complex lesions in the gastrointestinal tract. Dr. Nguyen chose to work at Providence Little Company of Mary to provide care in a hospital that excels in compassion and values each patient as an individual. He says that it is a pleasure to serve his patients and to work with outstanding endoscopic nurses, technicians, and ancillary staff at the Little Company of Mary. Everyone has a great attitude and work together as a team to provide the best care to our patients and acknowledge their concerns. When Dr. Nguyen is not working, he loves to run and hike and spend time with his family. So here, introducing you, Dr. Alexander Nguyen.
Thank you so much for that introduction, Nicole. And hello, everybody. I'm Dr. Alex Nguyen with South Bay Gastroenterology Medical Group. And I'm here today to talk to you guys about suffering from irritable bowel syndrome. And let's learn about how to identify and find relief from IBS. So disclaimer, I don't have any financial conflicts or relevant financial relationships to disclose. And this is a lecture purely for educational purposes. To start with, I'll discuss my outline. So what is irritable bowel syndrome, or IBS? And in particular, we'll discuss the Rome criteria, Bristol stool chart, the subtypes, prevalence, and natural history of IBS. Then I'll talk about when should I see a doctor if I'm concerned? What tests do doctors order, and what exactly are they looking for? And finally, I'll spend the majority of my time talking about what causes IBS and how is it treated. We'll go over the pathophysiology, traditional pathway of gut motility and visceral hypersensitivity, and treatments for constipation, diarrhea, bloating, and abdominal pain. I want to spend the majority of time here on information other than pharmacological options, because I feel when you see your doctor, they can help discuss in more detail the medications used and often have a little bit less time to talk about the overall picture of IBS. So let's get started. What is IBS? It's associated with many symptoms that overlap with other GI disorders, and often we have all encountered at some point in our lives, whether it be abdominal pain, bloating, distension, feeling gassy, cramping, pressure, flatulence, belching, constipation, or diarrhea. The main thing that differentiates IBS from just having these symptoms is the chronicity of these symptoms. So this leads to the development of what we call the Rome 4 definition of irritable bowel syndrome. This is strict criteria that was developed from consensus of the Rome Foundation. The Rome Foundation is a not-for-profit organization dedicated to the evaluation of patients with disorders of gut-brain interaction and providing information to help patients and doctors understand and treat these functional disorders. It's a consensus definition that's obtained from experts from around the world and is constantly being refined. So the Rome definition for IBS is defined as recurrent abdominal pain on average at least one day out of the week in the last 3 months, with the onset of symptoms at least 6 months prior, associated with 2 or more of the following criteria. 1, that the pain is related to defecation, not necessarily causing or preceding or following it. 2, that there's an association with a change in the frequency of stool. And 3, that there is an association with a change in the form or appearance of the stool. Now, the appearance of the stool is classified based on what we call the Bristol stool chart. So the Bristol stool chart defines the formation and appearance of stool. Type 1 is defined as separate, hard lumps, and is seen in patients who are very constipated. Type 2 is lumpy and sausage-like stool in patients who are slightly constipated. Type 3 is a normal appearance of stool, more like a sausage shape with cracks in the surface. Similarly, type 4 is also a normal appearance of stool, like a smooth, soft sausage or a snake. I'm not making these stool definitions up. It's what was studied and came up with. Type 5, soft blobs with clear-cut edges lacking fiber. And type 6, mushy consistency with ragged edges seen in inflammation or diarrhea, with type 7 being pure liquid consistency with no solid pieces and seen in inflammation diarrhea. Now, these images here are of different types of chocolate, but the point is the descriptions fit and help us classify the type of stools that patients may be experiencing. In general, type 1 and 2 may be more difficult to pass and indicate constipation. Type 3 and 4 are ideal. Type 5 trends towards diarrhea, while type 6 and 7 is actual diarrhea. This leads to what we call the IBS subtypes, or the different types of IBS that patients may experience. The strict definition is based on observation of bowel movements that appear over 2 weeks, while off any medications that may affect bowel movements. Remember, in total, this is for patients with abdominal pain at least once a week over the preceding 3 months. Now, there are 4 types of IBS, the first being IBS with predominant constipation, or IBS-C. In these patients, 25% of bowel movements are constipation, Bristol stool type 1 and 2, and 25% of bowel movements are without diarrhea. Now, another subtype is IBS with predominant diarrhea, or IBS-D. These patients have Bristol stool type 6 and 7, 25% of the time with diarrhea, and 25% of bowel movements are without constipation. The last 2 are IBS mixed, where you may have 25% of the time bowel movements with diarrhea, or 25% of the time bowel movements with constipation. And IBS unclassified, where it may not be possible or it may be difficult to classify the types of bowel movements. Now that we have an understanding about IBS, let's talk about the prevalence. So across the world, there's an estimated worldwide occurrence of 4 to 10% of people affected, which is quite a big number. In the US alone, about 45 million people are estimated to suffer from IBS. There's estimates that 40% of individuals who meet these formal diagnostic criteria set forth by the Rome Foundation for IBS do not actually have a formal diagnosis or are seeking care. It's not a life-threatening disease, but people with IBS average 14 days of missed work a year compared to 5 for those without IBS. Not to mention impairment on eating out, going out, traveling, social activities, or just trying to live your life regularly. Females are often more so than males to be affected with IBS as well, and tend to have more often a IBS-Constipation predominant type. So, suffering is a human condition. There's always something in our life we can't control or that we feel affects us uniquely. And it's human, a part of life to ask, why me? But we do not need to suffer alone. With IBS, it may be embarrassing to talk about, but as physicians, we are here to help and communicate. I went to medicine to be able to help others and have the knowledge and abilities to do so. Though I have a specialized skill set within gastroenterology, I see IBS regularly and is one of the most common disorders we help treat and diagnose. As physicians, we may not always know the answers, but we will do our best to help you if you come to see us. So the natural history of IBS, I think, is like the flow of a river. There appears a fast flow and stagnant water that can change with time. So patients with IBS typically have chronic symptoms that vary in severity over time. In one systematic review that included patients seen in clinic with follow-up visits over a period of 6 years, 2 to 5% did end up being diagnosed with an alternate GI disease. The remainder who were classified with IBS had 50% improvement. 30 to 50% did remain stable, and there was a small subset, about 2 to 18%, that had progression of disease. So I think it's important to work with your physician to determine treatment that works for you. So what does that mean? How can your doctor help? Well, it's important to see your doctor to evaluate for other overlap conditions that can include things such as microscopic colitis, small intestinal bacterial overgrowth, dysenergic defecation, psychiatric conditions, fibromyalgia, cancer, acid reflux. Seeking medical care is especially important to evaluate for what we call alarm symptoms that should be investigated before diagnosing IBS. So age of onset of symptoms after age 50 years does mean that we should do a little bit more investigation as physicians. Similarly, if a patient is reporting bleeding with bowel movements, diarrhea waking you up at night, progressive abdominal pain that's worsening, losing weight without trying, abnormal labs showing anemia, which is low blood levels, or inflammation, which is measured by special stool or blood markers, or family history that's significant for things such as inflammatory bowel disease, Crohn's, ulcerative colitis, celiac sprue, or colorectal cancer. All these things are things that your doctor is looking for to see and make sure it's not some other disease before considering IBS. So we also use, as physicians, different testing options in working up IBS. A complete blood count is a blood test that you go to the lab to get, and a colonoscopy may be done depending on age, your family history, or symptoms that you may experience. In those with diarrhea especially, we're going to check body markers of inflammation either through blood or stool, and these are things such as what we call fecal calprotectin, which is a stool test measuring protein expressed when inflammatory cells in the gut move around, or CRP, which is a blood test measuring inflammation within the bloodstream. We can also test for stool testing, including Giardia, which is a parasite, or blood tests that are specific for celiac disease, which is another gastrointestinal disorder. Sometimes we may go a step further and look at bile acids or do further imaging depending on our findings. Especially in patients with constipation, we like to do imaging studies of the abdomen, such as an X-ray to look at the degree of constipation in stool, and specific movement or motility tests of the function of the muscles that are controlling the rectum. The goal overall, though, is what we call a positive diagnostic strategy rather than a diagnosis of exclusion. In the past, IBS was considered a diagnosis of exclusion. This is a term that we use for when we diagnose something after we have exhausted all our other diagnostic tools, meaning that patients would go through blood tests, imaging, invasive testing, repeated testing to arrive at such a diagnosis. But as our understanding of IBS has grown, so has our confidence in diagnosing IBS without subjecting a patient to many costly, unnecessary, or redundant testing. This diagnostic approach often rules out organic disease confidently. And in over 95% of patients, we can confidently say that patient has IBS. Repeated testing is unlikely to be of benefit. So going from one doctor to another, trying to repeat or reinvent the wheel with another endoscopy, another colonoscopy is unlikely to help. Especially in patients with IBS-C, constipation is not a risk factor for colon cancer and not an indication necessarily for a colonoscopy unless there's those alarm symptoms we discussed. The goal with this approach is to minimize unnecessary diagnostic testing and focus energy on getting better and getting treatment for your IBS. So, as a doctor, I don't see my role necessarily as telling a patient what to do, but rather to synthesize the knowledge and data out there for disease and help a patient figure out the best way to help them feel better. So we have algorithms like this that help guide us and understand IBS. It's not simply a disease that is all in your head or something that you need to have repeat testing or necessary invasive testing done. With the more recent research and literature, and all these studies have been coming out in the past 2 years, doctors can take this information and develop a comprehensive treatment plan. This may mean, in some cases of mild IBS, doing nothing other than being more conscious of the life you're living and aware of what you eat and how you manage your bowel movements. While more severe cases, it may mean specific pharmacologic agents. So this leads me to want to talk more about what causes IBS. As a patient, why am I affected? What can I do? Well, every patient is different and every path is unique. So this is why it's important to seek professional help, because as doctors and healthcare providers, we communicate with you and figure out your path and how we can individualize treatment. Now, genetics may play a role yet to be uncovered, but it's not really something we can control. And so I want to focus on the pathways that are in our grasp to better control a patient's future with IBS. So I'm going to talk about the traditional pathways of disease that focus on alterations in gut movement or motility and sensations, something we call visceral hypersensitivity, and we'll get into this. I also will discuss newer research that's ongoing to evaluate inflammation, changes in the patient's microbiome and gut bacteria, and psychological effects of the brain-gut axis. So talk to your doctor. Symptoms can guide not only therapy, but also they point to possible etiologies. So there's many different pathways of disease, and we'll get into some of these that I mentioned. So our understanding has evolved. Like M&Ms, IBS isn't just one type or one color. It's not black and white, but we are discovering that it's multifaceted or multicolored. And it requires different approaches depending on etiology to sort out and treat. So talk first about gastrointestinal motility. The gut is always moving. It's moving food down, it's processing, digesting, absorbing nutrients. And in patients with IBS, there may be increased or decreased frequency or irregularity of contractions and movement. We've studied this motility, and there is no dominant pattern of motor activity that has emerged as a marker for IBS. Abnormalities that have been observed, though, include increased frequency or irregularity of the rhythm of luminal contractions of the gut, or a prolonged time of movement in constipation, or an exaggerated overactive response in diarrhea. Treatment, therefore, often aims to calm or speed up the gut movement to reduce gas retention and improve symptoms, depending on constipation or diarrhea. So let's first talk about IBS with constipation. Most important in these patients is to ensure first adequate fiber intake, psyllium being the most effective for IBS, sold as Metamucil. Now I'm going to talk more about fiber and diet in a little bit, but there are different types that may be effective for an individual. And so that's where talking to a doctor is important. Combining a fiber with the laxative is especially helpful, especially with the osmotic laxatives such as Miralax or polyethylene glycol. This medication is inexpensive, over-the-counter, and safe to use, having been around for many years. We'll often start with a spoonful, 17 grams or so, and go up as tolerated. These two things can improve constipation, but may not necessarily improve abdominal pain or bloating discomfort, which is often the main complaint of IBS. For this reason, seeing a doctor can help, as we may be able to determine if prescription medications targeting gut receptors is right for you. We have 5 drugs that treat IBS constipation. Linzess or linaclotide is first line for IBS with constipation, and its cousin is Trulance or procanatide. Both stimulate secretion in the intestines and movement through activation of specific gut receptors, namely something we call a guanylate cyclase receptor. Amitiza, also known as lubiprostone, has a different mechanism but acts similarly. Delnorm is another medication. The generic name is tegaserod, and it can help reduce abdominal pain and constipation, and possibly stomach pains as well. And has good use in younger patients, women under the age 65 without cardiovascular disease. And you may have heard of IBS Rela or tenofovir, which reduces sodium absorption and increases fluid volume and can show improvement in bowel movements and abdominal pain. Another point to make about IBS-C is that sometimes if medications do not give relief, especially in women, a consideration should be made for dysenergic defecation. In patients with dysenergic defecation, there's ineffective movement of stool passage out, and this can be associated with a failure to relax the muscles of the rectum or pelvic floor, which are centered around the anus and consist of the puborectalis muscle, muscles of mechanical barrier, namely the internal and external anal sphincter. In a normal defecation, these muscles relax to allow passage of stool. But in dysenergic defecation, these muscles are contracting, not allowing passage of the stool. This contributes to a vicious feedback cycle of constipation and pain that can appear, overlap, or mimic IBS with constipation, and can occur in up to 40% of patients with IBS. Patients who do not respond to conventional therapies for IBS-C may therefore benefit from additional anorectal physiological testing. And this can include things such as special imaging tests that you may have heard of, such as defecography, motility testing, or balloon expulsion testing. Biofeedback therapy and evaluation by a pelvic floor disorder specialist may be helpful, and there are some at Providence Little Company of Mary. Biofeedback therapy especially can be done where special electric sensors are placed near the pelvic floor, and that can give input if correct muscle groups are engaged. This can help a patient retrain the pelvic floor muscles in dysenergic defecation. Now let's shift gears and talk about IBS with diarrhea. This subtype, in which a patient has more diarrhea, the first line treatment is loperamide, which is a medication that is often sold over the counter. You can get it at a local pharmacy, and comes in 2 milligram tablets that you give about 45 minutes or so before meal, up to 8 tablets a day or 16 milligrams. This medication helps to inhibit movement of the gut and reduce stool volume. It works by acting on what we call new opioid receptors in the gut to stimulate them. We'll talk about Xifaxan and low-dose TCAs in a little bit, but I want to mention Viberzi, which is effective but should not be used in patients with liver disease, alcohol use, pancreatitis, or gallbladder issues, and Lotrinex, which is effective and recommended in women with severe IBS. But care should be used with this medication as it can cause colonic injury. So talk to your doctor to be evaluated further. So now that we talked about medications for constipation diarrhea, the number 1 and number 2 complaints though with patients with IBS is usually pain and bloating related to the IBS. We call this phenomenon visceral hypersensitivity, which is described as increased sensation in response to stimulus or triggers. In general, patients become more sensitive to the distension of the bowel, to bloating from hypersensitization or overactivity of these nerves in the gut. Now, we're not sure exactly why this occurs, whether it's a local gut nervous system, if it's coming from the brain, from central command, or is it some combination of the two to form what we call the brain-gut axis. Treatment here focuses on reducing these sensations. So oftentimes, doctors will start with an antispasmodic, and this will reduce contractions of the gut to calm it down. These medications are prescribed on an as-needed basis, being taken when a patient has symptoms, and include dicyclomine or bentyl, or another medication called levsin or hyoscyamin, and the more natural extract peppermint oil. These drugs work on what we call an anticholinergic pathway to slow down smooth muscle and reduce stimulation of the colon. There's also neuromodulators for those with persistent pain or bloating, which also can help calm the gut down through the brain axis and have an antidepressant effect of the anticholinergic pathway. Especially in patients with IBS-D, these drugs take a few weeks to start and are effective. They include amitriptyline or Elavil, or desipramine or norpramine. And of course, we can't talk about IBS without mentioning diet, which can play a big role. And typical for gas, you want to avoid things that can form gas in the gut, such as beans, onions, celery, carrots, raisins, bananas, apricots, prunes, to name a few things. So let's talk more about diet and food sensitivities. We know it plays a large role in certain patients with IBS, but there's still a lot we don't know, and investigations are still ongoing about antibodies, malabsorption, and sensitivity. But let's talk about what we do know. Lactose intolerance is a common thing, and we do see overlap with lactose intolerance in patients with IBS. Now, lactose is a sugar absorbed in the gut, in the small intestine, and there's a special protein or enzyme called lactase that breaks it down. And this enzyme is defective or missing in patients who can't tolerate lactose. So typically, a trial of eliminating lactose for a week is sufficient to determine symptoms. So milk, dairy products, cheese, any cow milk products. Sometimes doctors will order a breath test to confirm. In some cases, individuals may have intolerance to other milk dairy components like cow milk protein and not the lactose specifically. Another food sensitivity that we commonly hear about, and you may have heard about, is gluten intolerance. Now, this is often seen more so in patients with celiac disease. Gluten is a protein grain, such as wheat, rye, cereals, that can trigger an immune response. There's overlap in those with IBS as well. You may have heard of someone who doesn't have celiac disease try a gluten-free diet and feel better. And we're not really sure, could these patients, maybe they have early celiac disease, IBS, or both. One theory is that in IBS, since gluten is often associated with fructans, which is known to affect patients with IBS, maybe you're eliminating both, and that's how it helps patients with IBS. Typically, though, if you remove gluten, symptoms can improve in 2 to 4 weeks if this is a cause. It's important to talk to your doctor, though, before embarking on kind of these dietary measures. Another part of IBS that's important, and I mentioned this earlier, was fiber intake. It's also important, especially in patients with IBS-C. Dietary fiber is a carbohydrate that is not absorbed or digested in the small intestine. For IBS, soluble fiber minimizes bloat, gas, and distension compared to insoluble fiber. So these are two different types of fiber. Soluble fiber is found in things such as psyllium or metamucil, corn fiber, oats, and the fleshy part of fruits and vegetables. In contrast, insoluble fiber is found in wheat, whole grains, and the skin and seeds of fruits and vegetables. Soluble fiber will dissolve in water and form a gel with it, aiding digestion and promoting good bacteria in the gut. In contrast, insoluble fiber, it's good, but not so much for IBS because it doesn't dissolve in water, and it may cause a little bit more gas formation in patients with IBS. So now that we've talked a little bit about dairy, gluten, fiber to the diet, let's talk about what the best diet is to help with IBS global symptoms, that is, any patient with IBS. And that is probably what we call the low FODMAP diet. You may have heard of this. What are FODMAPs? FODMAPs is an acronym. It stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, which is a mouthful. These are short-chain carbohydrates or small sugars such as fructans that the small intestine absorbs poorly and may cause intestinal distress. So think of This is kind of, I don't know if this works, but think of brushes, sponges, and wipes of an automated car wash and how it scrubs off the car. Similarly, in the small intestine, there's a scrubbing or absorption process from the surface of the small intestine that is at work. FODMAPs are more resistant to this process and take extra work to be absorbed. And once FODMAPs reach the colon as well, they can cause fermentation, which creates the gas and bloating. A low FODMAP diet thus seeks to eliminate FODMAPs or at least minimize them to allow for decrease in global symptoms of gas, bloating, and pain in a patient with IBS. So what exactly is consistent in a low FODMAP diet? Well, like the word itself, it's a mouthful. There's so many different foods that contain FODMAPs. So really, it's hard to eliminate all of this. So in a real FODMAP diet, there are 3 steps to a low FODMAP diet. The first is to stop eating certain foods, high FODMAP foods, for about 2 to 6 weeks. This is where working with a dietitian or nutritionist rather than a physician can help, as you can avoid unnecessary diet restrictions and really tailor your diet to what works for you. Most common triggers here are wheat, garlic, and dairy. The second step is to reintroduce over a period of 6 to 10 weeks different foods to ensure that you can see what foods are tolerable. You do this every couple of days to kind of see what foods trigger your symptoms the most. This leads to personalization of the diet and ability to modify it and use it as a starting point to return to if you have a flare or worsening of your IBS symptoms. In this way, you can avoid or limit foods that cause symptoms long-term and personalize the diet, working with a dietitian, nutritionist, or your healthcare team. So there's a lot on the low FODMAP diet, so I want to take a minute and just give you some resources for the low FODMAP diet. About 50% of patients will improve with this diet alone and not necessarily need any other kind of treatments. Here, a registered dietitian can really help, and eatright.org has a great resource for many dietitians that you can look for in your area. Some patients may be great cooks, and following a recipe book, such as the low FODMAP diet, can be helpful in tailoring food and nutrition for yourself. Or you may not be a great cook like myself and want to have food prepared for you. Nowadays, we have food subscription services, and Epicure has tailor-made food delivery and preparation subscriptions for patients who may not have the time to cook. Some patients can do things on their own and like to be on their smartphone all the time. So you can take control yourself with things such as the Monash University FODMAP app. And Monash University is where the FODMAP diet was first studied. It's $8 on the Apple App Store, so I like this app. So sometimes though, the FODMAP diet may be difficult to maintain, and a lot of times patients want to know, can you check for food allergies? Is this something that can be done? But unfortunately, really food sensitivity or allergy testing is limited in utility in patients with IBS. It's mainly used in patients who have an allergic reaction to food. And this is things such as right after you eat or up to 2 hours after you eat, you're developing swelling of the face, itching, wheezing, nausea, vomiting that occurs after eating. Not so much the diarrhea or constipation or abdominal pain of IBS. If you do have these symptoms though, talk to your doctor, because referral to an allergist for education or confirmatory testing such as skin prick testing or blood testing may be indicated. So this is kind of dancing around the idea of inflammation. Despite the limited role of food allergy testing, we are looking a lot at how is the gut responding, how's the immunological response of the gut to food occurring within the intestines. So such diseases that have been born from this include studying lymphocytes, mast cells, cytokines, and discovering diseases such as celiac disease, eosinophilic gastroenteritis, mast cell activation syndrome, maybe even inflammatory bowel disease. In the future, IBS may be categorized based on these different inflammatory pathways that are under investigation. Inflammation is also seen in patients who have an infection. Similar to an overactive inflammatory state, there has been some theories that IBS can follow gut infection. there's an idea that maybe after you have malabsorption or increased inflammation after infection, then you can develop IBS. And we do know that the longer or more often a patient gets sick, the more increased the risk for IBS. So this led to studies on really bad food poisoning, those from food bacteria such as E. coli, Shigella, Campylobacter, that have been linked to involvement of a special toxin in bacteria called cytolethal dissetting toxin B and antibodies to a human protein called vinculin. About 30% of IBS-D patients may have had an infection that started or that occurred before they developed the IBS. There is a blood test called IBS Smart for patients with IBS-D after gut infection, but a lot of times you can just know this from your own history. But for those who want a little bit extra reassurance or just to confirm, this test is pretty good for supporting a positive diagnostic strategy and showing that there was likely an infection that led to the IBS. So this is something you can talk about with your doctor if it is right for you. Ultimately, there's still a lot we don't know about the gut microbiome. There's thousands of different species with more diversity than the human genome residing in our gut, about 100 times more complex than our own DNA. All these bacteria reside in the small intestine, but more so in the colon. As advanced as we are, there are many interactions and battles between the many different species that we aren't even aware of or comprehend. So we may have all these technological advances, but even the smallest thing is something we don't know about yet. One theory for treatment in this case is, of course, antibiotics. In particular, rifaximin or Xifaxan is a great medication for treatment of IBS-D. It stays in the gut and is not systemically absorbed, so it's only acting locally and has minimal side effects. It fights to reduce bacteria, particularly those that are gas-producing. Taken orally, it is generally well tolerated and it can improve symptoms of bloating, pain, in addition to the diarrhea. We also use this medication in other diseases such as bacterial overgrowth or mental clouding due to patients who have liver disease. Another thing to think about is rather than focusing on killing off the bad bacteria in the gut with antibiotics, science has also looked at fishing for and finding the good bacteria to cultivate and grow. Perhaps finding these good bacteria and helping them grow can improve our gut health. This is the appeal of probiotics and prebiotics. Here, I think the enthusiasm is outpacing the science. As intuitive as it may sound, identifying the correct strain in a pool of thousands of different gut bacteria to promote gut health is not as easy as simply taking a probiotic that you see on the shelf. On the one hand, we have prebiotics, which are not bacteria, but are carbohydrate substances that the bacteria in your gut feed on and grow from. There's no strong studies to support this use, and we don't really know if you're with probiotics, you're causing fermentation of bad bacteria in addition to good bacteria. So there may not be a benefit here. On the other hand, probiotics are the actual bacteria found in food or supplements and in your gut. Some studies have shown benefit of probiotics, but often they are for single strains and small in scope. At best, I'd say probiotics have some effect on symptoms. At worst, they may cost a little bit and may not do anything. We do, though, have a few large studies looking at an aggregation or combination of all the different probiotics that have been studied. Recent guidelines in particular, have looked at 44 different strains of probiotics over 55 trials, looking at over 5,000 patients. We do see a significant trend in patients who are taking probiotics that are multi-strained. So two of the strains that have been studied are VSL number 3 and BioCult, which has 14 different strains, but there are many others, Align being one of them. So let's talk a little bit about the microbiome. Future research looking more at this may improve our use of probiotics, diets, and medical therapy. Right now, a lot of things are being thrown around, but we don't have a great pathway forward, and things are kind of up to patients to see what works for them, what doesn't work for them, rather than having a tailor-made direction that a doctor can advise you on. So areas of potential benefit for IBS patients could incorporate breath testing. And this is something that is utilized in patients with bacterial overgrowth, or SIBO, that can be found in about 30% of patients with IBS-D. These breath tests are looking for gases that are produced from gut bacteria, such as hydrogen, methane, hydrogen sulfide, and can help determine if you have IBS-D or C. It's done by having you come to a lab or at-home test, take a carbohydrate like lactose or glucose, and then measuring the gas output. Another testing option, stool testing. Looking in the waste of our stool has been studied as a potential source for testing our microbiome. Now, these studies have not been as well validated as breath tests, but they do provide a lot of data, but honestly, we're not really sure how to interpret this. So you may have heard of tests like TrioSmart, which is an at-home breath test for SIBO that a doctor can order, or Viome or Biome, which are at-home stool tests and blood tests that look at the gut microbiome or fungi, the fecal flora. Again, these tests aren't well validated. There's no clear consensus or guidelines among physicians about what to do with the results. So take these tests with caution, but they are available. So, with all this information, it can be a lot to take in as a patient. And of course, many patients with IBS suffer from psychosocial dysfunction, such as anxiety, sleep problems, depression, phobias, or severe stress. So there is a big component, a psychological component of IBS, and that's what we call the gut-brain axis. One possible hypothesis is that with the brain-gut axis, there's excess signaling of corticotropin-releasing factor peptide in the brain. As physicians, we can prescribe medications such as neuromodulators or antidepressant tricyclic drugs. Often patients want to know about complementary and alternative medicine, such as cognitive behavioral therapy, hypnosis, acupuncture, yoga, or cannabis. And I'll just say that it's important to talk to your doctor about these alternative and complementary medicine and determine expectations, treatment course, and potential adverse effects before embarking on a trial run. A lot of times, though, about 2 to 4 weeks of these things will be enough to see if it's effective for you or not. One aspect of psychological treatment that has shown benefit is something we call cognitive behavioral therapy, or CBT. This has been studied, and it has been effective in patients with IBS in randomized controlled trials. It's a form of psychological treatment based on actionable items. And the idea is that feelings, thoughts, and behavior are all interlinked. Some problems may be based on unhelpful or negative ways of thinking or learned patterns of bad behavior. With CBT, the goal is to focus on actionable things you can do to change your thinking pattern and break bad behaviors with different coping skills. Overall, with these treatments, the focus is on mindfulness, or having a greater sense of confidence in yourself that you can fight this disease, and self-awareness about what's going on with your body and in how you interact and your relationship with this disease. The CBT treatments are reproducible, and there has been studies showing that you can do this through video-based conferencing with a provider. And so it's easy I should say it's studied more often in IBS than other forms of more personalized psychotherapy, such as hypnosis or more deep psychotherapy that may also be effective, but not as well shown in literature. So in conclusion, IBS-D and IBS-C are diagnosed by the Rome criteria, where we have 25% of your bowel movements are different, diarrhea, constipation, based on the Bristol stool scale, with abdominal pain over the course of 3 months. Doctors will work you up with a positive diagnostic strategy, looking for alarm symptoms and an overall goal of making sure that you have limited lab testing and not throwing the kitchen sink at the diagnosis. Traditional pathways of gut motility and visceral hypersensitivity are targets for pharmacological therapy. or to talk to your doctor about what treatments are right for you. We also discussed biofeedback therapy and dysynergic defecation. The microbiome and diet play an important role in IBS, with research ongoing about probiotics, prebiotics, and how the microbiome fits into all of this. Antibiotics can help, such as rifaximin, and we talked about the low FODMAP diet and its role in IBS. And finally, psychological component of IBS is important to address, and seeking out a good psychiatrist that you trust and buying into the fact that this is something that you can control with changing how you think can really have a good impact on treatment of IBS. And cognitive behavioral therapy works here. So the future of IBS looks good, and ultimately, there's a lot of information out there. So thank you for listening. These are some great resources for more information as well. The IBS podcast is put on from a patient with his own experiences from the disease, and the IBS support group is run by patients for patients. If you want more detailed knowledge, I recommend looking at the primary data that physicians and healthcare workers look at every day, namely guidelines that are put forth from our national society. And talk with your physician, talk with your healthcare provider. The first step is taking charge and taking control of your own health. So thank you very much, and I'll open it up to questions. Nicole?
Hello, everyone. Before we begin the Q&A, I just wanted to reiterate that the information provided during this program is for educational purposes only, and you should always consult your healthcare provider regarding any medical condition or treatment that you have concerns or questions about. And also, we do have some questions for you. So you're going to see a poll show up on your screen with a few questions. So please give us some honest feedback, and we'd be grateful for it. Okay, so I'm going to go ahead and start with some questions for Dr. Nguyen. Let's see. What role does stress or levels of cortisol play in IBS?
So definitely stress plays a big role in IBS. As discussed, there is a strong psychological component to the disease, and being able to manage your stress and address it either through pharmacological therapy, addressing the diarrhea, constipation, and pain, or psychological therapy, addressing your relationship to the disease, or dietary therapy, where you have control over what you eat and put into your body, can help reduce the stress levels that IBS may contain. It's a complicated disease because when you have pain, you're under stress, and it can create a feedback cycle. So it's hard to say what's causing what. Is stress leading to IBS, or one of the main factors causing it, or is a lot of the stress because you have the IBS?
Okay, to our second question from Karen. How long can someone stay on a low FODMAP diet? I've heard it's only to be followed short term. Is this true?
Yeah, so like I talked about when we discussed the low FODMAP diet, you're right. In the past, doctors would say, just go on your low FODMAP diet. But studies of patients who stayed on it showed that even those who are very confident in low FODMAP diet, you can have times where you have slight malnutrition. So now we say that the FODMAP diet is best used in a short period of time, about 4 to 6 weeks, and with a dietitian or nutritionist or your physician, and you're really working to first eliminate these high FODMAP foods and then slowly reintroduce it back into your diet. So really, you should use the FODMAP diet as a starting point to personalize your diet and see what can best help you and what may trigger your IBS and you want to avoid.
This question is from Albert. For the drugs that treat visceral hypersensitivity, how should their effect be noticed, if effective? Are negative side effects likely or have long-term effects?
Yeah, so there's different medications here. The most common first line being antispasmodics, Levsin, bentyl, peppermint oil. Often these are given on an as-needed basis, because the idea here is that when you take it, it should be able to help you, within that same day, within a few hours at most. So those medications are effective there. And if you're on a trial of it for 2 to 4 weeks, you're not having any response, you follow up with your physician. At that point, we may look at other medications or treatments. Neuromodulators being things such as tricyclic antidepressants, which do take a few weeks to really ramp up and get to a point where it can help you. Or non-pharmacological therapies such as diet or psychotherapy such as cognitive behavioral therapy. With the neuromodulators, they work on what we call the anticholinergic pathway. So there are some side effects depending on the dose of it, but we do use very low doses of these medications that are designed to focus on the gut.
And what medications are most likely to cause IBS?
What medications are most likely to cause IBS? In terms of the causes of IBS, I'm not sure if there are medications that are known to cause it. It's not in the traditional pathway of what we think of causing IBS. Now, maybe a medication can cause symptoms that mimic IBS, but I don't think there's been any studies looking at correlation of medications causing IBS. So let's say you have IBS-Constipation and you're taking something like Linzess or Trulance, and now you're having a lot of diarrhea. Do you now have IBS-C or IBS diarrhea? Not necessarily. This is maybe just a side effect of the medication. So I don't think any medications necessarily cause IBS, but they can maybe cause symptoms that overlap with IBS: diarrhea, constipation, bloating, abdominal pain.
This is from Yolanda. Is there any link with gallbladder removal?
Link with gallbladder removal? Yeah, that's so a couple of things with the gallbladder being removed. One of the things that sometimes we see in rare cases with patients is diarrhea and excess gas. So that looks a lot like IBS. And there's a disease that we call bile acid diarrhea that can overlap with IBS. So a lot of times, if a patient's not improving with the typical treatment and workup for IBS with diarrhea, doctors do check for bile acids, or they'll start you on what we call bile acid sequestrant, which may be targeting bile acid diarrhea. And we see that in patients who have the gallbladder out. Another important thing is in patients who have the gallbladder out, there are certain medications that treat IBS that doctors need to be aware of that has happened, because it can affect and influence the medications you get.
Question from Jonna. Is it possible to be suffering IBS for a long time without realizing it? Maybe it was presented already, but could it cause other types of gastrointestinal diseases in the long term?
Yeah, good question. It is possible to suffer from IBS for a long time. It's not a life-threatening disease, so a lot of times patients may suffer from it and not really seek care for it. It's estimated about 40% of people in the US have IBS symptoms and don't really seek care for it. And it is something that you may have and just shrug off, especially if you're able to just kind of power through it. Long term, we have seen that IBS, 50% of the time with treatment or care, can improve. Another 20% of the time it stays stable, or 30% of the time it stays stable, and 2 to 20% of times it may worse. So it's important to talk to your doctor about that. Now, IBS hasn't really been linked. Well, it's not going to lead to cancer. It's a benign disease, and that's why when you see your doctor, they want to check for these alarm symptoms. Excessive diarrhea, especially at night, waking you up, bleeding in your stool, pain that's progressive, if the age of onset is over age 50, if you have a family history of inflammatory bowel disease, such as Crohn's or colitis or colon cancer, or have abnormal labs.
A question from Kim. Have you seen vomiting and early satiety with patients with IBS?
Early satiety and vomiting, sometimes patients with IBS do complain of that. But it's not, if those are the main complaints a patient comes to see me with, IBS is not what I'm thinking about as on the top of my list, because IBS is mainly abdominal pain, bloating, gas with diarrhea and constipation. So vomiting and problems with eating aren't necessarily part of that definition. But there is overlap, and we do see those disorders in patients who may have concurrent diseases or an overlapping disease. It's not, I mean, you can have IBS, but you could also have like a stomach infection, say like H. pylori, or have diabetes and gastroparesis. These things can overlap. So that's where talking to a doctor who can help differentiate everything and figure out what exactly is going on is important.
From Maryland, please speak a little bit about fibromyalgia and IBS.
So we do see overlap in patients who have IBS and fibromyalgia, because IBS, you have gut hypersensitivity, visceral hypersensitivity, and fibromyalgia, you have generalized neuropathic hypersensitivity as well. So there's a strong overlap between the two. I think when there is overlap like that, I like to work very closely with rheumatologists and neurologists to help manage both the fibromyalgia and IBS, because there are good treatments for fibromyalgia, and controlling the fibromyalgia may help to improve the IBS as well. A lot of times we have to pull in a multidisciplinary team to manage these conditions, and I think having help with the psychologist as well to kind of manage your relationship with the disease is important.
Thank you all for your questions. That will be the last question of the day for this session. Thank you all for taking time to listen and to ask questions. And a huge thanks to Dr. Nguyen for taking the time to provide us with this very valuable information. Just to answer, many of you wonder if we're going to be sending this out. You will be sent a recording of the presentation. We also will be posting this on our Facebook page for everyone to be able to view and share. And you can find us at Little Company of Mary South Bay on Facebook. And for any additional information or to schedule a physician appointment, please call our Patient Engagement Center at 844-925-0942. It's 844-925-0942. And thank you again, and have a great rest of your evening.
Thank you, everybody. Have a good night.